Hello everyone, welcome back to my YouTube channel. I am Dhriti Patel, a final year medical student from Ahmedabad, and today we are going to talk about how to get a distinction in ENT or how essentially to study the subject for your third year exams. Now there are two strategies, front end strategy and back end strategy, and you have to decide which group you want to put yourself in. How we go about with the front end strategies is you have the whole of year in mind. You have just passed your second MBBS and you are having fun and you're enjoying your life, but you're thinking about what you want to do for your third year exams. That is the front end strategy that you've already started thinking about it. And with this line of thinking, you utilize your clinical postings to their maximum abilities. You use your college resources, as in the patients, professors, residents, everyone to the maximum benefit. There is a back end strategy where it's the start of the year, you're not thinking about anything. You've decided that जो भी होगा देख लेंगे, last महीने में पढ़ाई हो जाएगी. That is not something I would support because that is kind of a risky thing to do. If you don't want to start studying, at least you have to start thinking कि वो last एक महीने में what are you going to study. I would obviously suggest go with the whole year approach rather than already thinking about the last month approach. But फिर last महीना आया and you've not studied anything, so you're gonna have to go with that only. So let's get started. I would also like to give a disclaimer. Distinction is when you score 75 or more than 75% marks in any of your exams. So for ENT, that looks like if you've scored 150 or above, then you have gotten a distinction. If you are watching this video as a how-to study guide for ENT, then you can skip this disclaimer. But for those who are actually watching this with the wish in mind that they want to get a distinction in ENT, I'll suggest a mindset. We have the theory exam and the practical exam, right? And for that, I'll just say that we have more control over how we score in theory than the amount of control we have over how we score in practicals. In theory, you have to write the paper. They have to check it, yes, but you are writing the paper, okay? And what you write in what question, that's on you to decide. And whatever you study throughout the year, that distills down into what you write on the paper, right? So that is in your hand. You decide what you write on the paper. And then there is the other practical wala thing. You don't know which case you're going to get. And even if you get an easy case on the exam and you give a good viva, you don't know what marks they're going to put. Obviously, you do think about the practical skills as well, but if you're aiming for distinction, you have to get maximum marks in theory. I got 82 marks out of 100 on the theory paper, and I'm really, really proud of that. That's it. That's the disclaimer. The first section is of books. For ENT, everybody follows the same textbook. That is Dhingra, and that's a really good book. And there's no doubt about it. It's a book presented in a concise manner, concise enough to be able to write the same thing on the paper, and concise enough that it does not become a task to read it even throughout the year. You'll enjoy reading the book right from the start. For practical, we have Vikas Sinha. And I would not suggest you to get the actual book, just get a PDF of it, and that will do throughout the year, throughout your clinical postings as well, and even while studying before the exam. I don't think there are any other or better books. I don't think you even need a better book than Dhingra because it's a beautiful book. It's very straightforward, right up to the point, and with the appropriate amount of content for an undergraduate student. Then we come to a major segment that a lot of students in a lot of colleges miss out on. I don't think even we utilized our clinical postings to the best of their abilities. It's just that coming in final year, I realized what could have done better in the third year itself. So that's it. In the postings, what you're supposed to do is learn. You're cementing your theoretical concepts and you're building your practical concepts, your skills as a clinician. And there are such knowledgeable people, the professors, the residents, they are all amazing. So use them to your advantage. If you show a little interest, everybody will reciprocate your interest. So don't be shy. Ask anyone about if something is bothering, if you can't understand something, or if you're interested in something. Use your professors and your residents. That's all I'm saying. And one more thing is, if you asked somebody to explain you something once, and they did, and you did not get it, don't be shy to ask again. So for if you're looking into the otoscope for the first time, you're not gonna see anything. And that's okay. And even if they tell you once that you're supposed to look for this, you don't see it. That's okay. Go again and again. Maybe not today if they are in a bad mood, but go tomorrow. Be persistent, be insistent, and be consistent. Right at the start, ask what cases will you be getting for your practicals, and whenever you get a chance to see the patients of those, observe them, examine them, take histories, whatever your exam is going to test you about, start practicing those things, those skills right from the start of the year, so that when you are actually appearing for the exam, you don't even have to think about those things. Go and watch the surgeries, ask the residents to explain what instruments are kept, why are they needed in this particular surgery, why are they not needed in the other surgeries, how to identify the instrument, what are the uses, on the practical and the table viva, the instruments, the x-rays, everything is kept on there, right? You're supposed to identify the instrument, give the uses, how to hold it and everything. So start learning those things right from the start. And also one more thing is, get a tuning fork even if you're not supposed to carry one yourself for the exam. It's not that expensive. I think it's something 200-300 rupees on Amazon. You can get 1 or 2 or 3 or whatever. We have the Rinnes, Weber's tests, right? Start doing those tests. Maybe not on the patients right away. Maybe on each other. And you have to accept this. Our friends are our biggest resources. They can be our first patients. Maybe not patients, but they can be our first guinea pigs. On them, we can see the normal responses, so that when we see the abnormal response in a patient, we actually know that this is the abnormal response, because we know what normal looks like. In the first year itself, we start off by pricking ourselves or our lab partners for physiology practicals and testing our blood groups and everything. Then we learn how to take the BP, that too on our friends. The first blood sample I collected was of my best friend. And even right now, in the final year, in our medicine postings, we check our responses, our motor reflexes and our sensory reflexes, and we perform all the examinations first on each other. So use your friends, do the tuning fork tests on your friends, on each other, and see what responses you get. You have to treat the patients as human. They have lives, they have husbands, they have wives, they have kids, they have families, they are human. So don't treat them as guinea pigs. You can treat your friends as guinea pigs. They don't care, you don't care. But don't go experiment on the patients. If you're not confident to do something, go learn it first and then do it. Yes, you won't be confident on your first time on the patient, whatever it is, but you have to be smart enough to know what is the first time anxiety and what is actually a lack of skill. So if you don't know how to do something, first learn it. First, watch it be performed many times and then go ahead and do it yourself. The patient is not the guinea pig. Your friends can be. Triti 2024. I'll mention the next thing because I used it. It's not a necessity per se. You can even score amazing without it. I got Marrow in third year itself. There are 3 things, right? We have the lectures, we have the notes, and we have the MCQs. Dr. Manisha is an amazing teacher, and you will most definitely fall in love with her and the subject via her. She talks to you. It's not just a lecture about a certain topic. She is actually talking to you, and that's really good to study. And while you are watching the videos, annotate your notes. In some areas, she has explained so good that I have written in my notes that watch the video from this part to this part, because she has explained it so well. And the next time you read, you'll go back to the video and watch that little segment, and you'll have a clearer understanding of the subject. These are my Marrow notes that I heavily used throughout the year. You can make little diagrams such as these to simplify your concepts, little summary sections, then again little diagrams to help. One thing that I would like everyone to add to their notes is the etymologies. I love to know how a word got formed, who named it, who named a disease, and that helps a deeper and a clearer understanding of all the concepts. For example, if you think about rhinoscleroma and rhinosporidiosis, they sound very similar. But if you think rhinoscleroma, rhino means nose, that's common in both, rhino. Sclera means hard. Sclero means hard. Okay. So that's sclera, the outermost layer of the eyeball. We have sclerotherapy for varicose veins. So sclera in rhinoscleroma, the clinical features, one of the most important clinical features is a woody hard nose. Then we have rhinosporidiosis. You say spore and you think fungus. So that helps you remember that it's a fungal infection. Medicine is what I'm doing, but at heart, I'll always be a language lover. Reading, writing, everything, that's my forte. See here again the etymology section. Rhinolalia. Rhinolalia clausa and Rhinolalia aperta. Aperta means open. Rhinolalia. Rhino means nose. Lalia means to talk or chat. Then you have clausa. It's from claudere. That is shut or close. You think clausa, you say close. So there's closed and there's open. Then we have MCQs, nothing much to say about them. You solve them whenever you can. Don't delay them to the end of the year so that you're like, now I have to focus on university exams, now I can't solve MCQs. Don't use MCQs as a testing tool, use them as a learning tool. One more thing you can do is make mind maps. Mind maps, flowcharts, summary pages, whatever you might call them. I started to make these 1 month before my prelims. These are the one-page summaries that I was talking about. There's cholesteatoma, one-page thing. There are the theories, the classification, the complications, CSOM in one page, SOM complications in one page, extra. These are just points, the headings that you can have in your head. Then there's DNS. I've written etiology. There's only 2 main etiology. There's types. There are 5 types. See, middle ear anatomy. That is my diagram. These are the roof floor. All the pointers only. This is the one-page summary. Boundaries, 6-sided cavity, whatever 1, 2, 3, 4, 1, 2, 3, 4. I've written diagram is to be drawn in which of the following. Then there's blood supply, lymphatic drainage. Only points for yourself to remember. Tympanic membrane, 2-page. Ototoxic drugs, anatomy of facial nerve, JNA dysphagia, Plummer-Vinson syndrome, peritonsillar abscess, Quincy, Ludwig's angina. Just a lot of important topics. Rhinosporidiosis, adenoid hypertrophy, tuning fork test. You can use these things as both an active learning tool and a passive learning tool. You can read them, that's a passive learning tool. And for active learning, you can try to read them, try to remember them, and try to recreate them on a blank piece of paper. That is how you cement your understanding of the topic. So before the exam, for all the 10 marker questions, you have a 1-page thing of all the pointers. What are you supposed to write? So you have the headings set in your head. So on the paper, you just have to go write those headings and fill those details up. Then one thing you can do is the signs. Write them separately. There are 6 pages worth of signs only in the whole of ENT. These are of so much help for writing 2 markers. So written the name of the sign, where it is seen, and what is the process, observation, and inference. These are the 3 signs of meningitis, not important for ENT, but I read them on a later note and felt they could be asked, so wrote them. I've written the page number on which it is present in the Marrow notes. Schwartz sign, Tumarkin crisis, Tullio's phenomenon, Hennebert sign, everything. And also I've written little pointers for me to remember. For example, Tullio's phenomenon, I remember that there's double L, so it's loud. So it is what I go to loud sounds. They are all seen in Meniere's disease. Tumarkin crisis is drop attacks. Tullio's is double L is loud. So what I go to loud sounds. Hennebert's sign is what I go on pressure changes. Then these are all the signs seen in allergic rhinitis. Allergic salute is this persistent rubbing of the nose causes these creases on the nose. Allergic shiners are the dark circles around the eye, Denny Morgan lines. This is it. Another thing is the triads. 15 triads in the entirety of ENT, and that's it. Ramsay-Hunt syndrome, Melkerson-Rosenthal syndrome, Bell's palsy, Graden-Nigo syndrome, Van der Hoeve syndrome, Meniere's, Samter's, Young's syndrome, Carter-Jenner, Hereford, Trotter-Stryer or sinus of Mercagni syndrome, Plummer-Vinson, acute epiglottis laryngeal disease or laryngitis, and there's Behcet disease. That's it. That covers all the important, non-important, the sidelines wale triads as well. Trust me, I've looked through the whole of Marrow notes, the whole of the textbook, the whole of the internet, almost, I guess. And this is it. There are only 15 triads in ENT. I did the triads separately because I love them. I don't know, I just find that very cute. And triads are also asked on the exam for 2 markers and 6 markers. So there is that also. So do triads and signs separately. Another thing that can be added to your notes is diagrams. Now I did not do this for ENT because throughout the year I had studied ENT very well and I was pretty confident that I'll be able to draw the diagrams as required for the question. So I did not need to make a separate copy. But I did that for Ophthal because I did not study Ophthal throughout the year as well as I could have. So at the end I was kind of stumped and I needed a separate book for writing all the diagrams. That's here. And it's all the diagrams. Fundus changes in pathological myopia and astigmatism diagram. Then there's these diagrams, trachoma, conjunctiva anatomy, WHO classification of trachoma. Then we have VKC Venn diagram and the classification. It's not just a diagram, it's diagrams plus the explanations. Vernal keratopathy can cause these 5 stages. Another thing that a friend of mine did was she made these notebooks, these 100 to 200 pages notebooks of every subject. They had all the important questions that could be asked on the paper. And they were amazing. I preferred my analog notes throughout the year. But at the end, after I've gone through my textbook, my notes and everything that I have, I used to read through her notes as well. So that gave a quick brush up of the entire subject in one go. The next resource is YouTube itself. YouTube is an amazing free platform that you can use for your academics. Now there are a lot of amazing YouTube videos about examination and theoretical concept explanation, but I won't go into that. There's this amazing one where the guy actually goes inside the middle here and shows what is to his left, right, up and down. So that's an amazing video. I'll link it in the description. Then there are a lot of videos for practical examination, so check out those as well. But the one thing that I want to specifically point is the surgeries. Watch surgeries on YouTube. You might not get a chance to watch a lot of surgeries in your hospital. If you do, then that's well and good. I'm so happy for you. But if you don't, then YouTube is your way to go. And also one more benefit that I believe YouTube has over actual witnessing of the surgery is that it's on your phone. One. And two, it is that you look up canal wall up surgery, canal wall down surgery, and you'll see 10 videos. Okay, if you watch all of those 10 videos, you will see what are the common things in them and what are the differing things. What are the steps that all the surgeons are doing and in what way they are doing. Because even if there's a specific framework on how to do a particular surgery, the preferences of the surgeon, the condition of the patient, everything demands for customizing the surgery. So if you watch 10 videos, you'll see what are the common steps and you'll know what is everyone doing. What is that one step that nobody is missing? What is something that everybody is paying attention to? So that will increase your intuitive understanding of the surgeries and you'll be able to write the surgeries on the paper very easily. Otherwise, understanding surgeries is a task because without having done it, without having much knowledge about the anatomy, you don't get a grasp of it. That also helps in identifying the instrument, how to hold particular instruments. So do give YouTube a try for that. And that's all I have for today's video. Thank you so much for watching. I hope the third year students who are watching at least got a framework of what to do in their head. Share it with your friends, share it with your juniors, seniors, whoever is concerned, whoever is going to give the ENT exam, the third year exams this year. Best of luck for studying, for the exams, for whatever you're going to do in your life. Best of luck. Thank you for watching. See you in the next one.